Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison. It's my pleasure and privilege to serve as the host of the CGNE Seminar Series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing at Penn State in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar, Compassionate Care for Persons with HIV/AIDS at the End of Life, will be co-presented by Dr. Kiernan Riley and Megan Lucey. We welcome Kiernan back to Penn State, where she earned her doctoral degree, as well as Megan, a BSN student who is currently one of our CGNE Gero Scholars. Before the presentation, we do have some disclosures and announcements. The Pennsylvania State University's campuses are located on the original homelands of the Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, and Wazi nations. As a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the longer history of these lands and our place in that history. The Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Credentialing Centers Commission and Accreditation. So if you're a registered nurse participating in today's program and you attend the full session, you can earn 1 contact hour. Partial hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. We do record Zoom in and out times for attendance purposes, and there is a post-event evaluation survey that must be completed. We'll share the link to that survey later in the program, but it will also be available to you via email, and we need you to complete that within a week of the seminar. Certificates will be emailed to RNs that met the requirements within a month. This seminar is being recorded. If you happen to have any questions for our speakers or wish to share a comment, you can either enter those into the chat or you can raise your hand and Jenny will unmute you. Thank you, Jenny Rank, for your help as always. If you have any questions at all, you can reach out to cgne@psu.edu. So it's my pleasure now to introduce Olivia Rubio, one of our CGNE PhD affiliate students. Olivia is actively engaged with our center. She's also a team member of the Age-Friendly Care GWEP and was instrumental with developing community resource flyers to assist people with identifying and accessing services in every Pennsylvania county. Thank you to Olivia for introducing our speakers today.
Thank you, Janice, and good afternoon. Kiernan Riley is an assistant professor at Fitchburg State University in Fitchburg, Massachusetts. She graduated from Penn State Scranton with her Bachelor of Science in Nursing in 2018, and from Penn State University Park with her PhD in Nursing in 2021. She has worked as a home health, hospice, and pediatric nurse since graduating in 2018. However, her passions lie in hospice and community death care. She received training as a death doula in 2022 and hopes to continue to bring death awareness to the area. Kiernan remains active in her clinical practice, serving as a hospice registered nurse through Faith and Family Hospice in Marlborough, Massachusetts. Her research focus is on persons with severe and persistent mental illness and their end-of-life experiences. Megan Lucey is a senior honors nursing student at Penn State's Scranton campus. Her interests lie in critical care nursing and nursing research. She has co-authored 4 published manuscripts and was the lead author on one. Megan aspires to serve the community through nursing and inspire others. In her spare time, she runs on the cross-country team on campus and creates art.
So I'll start sharing my screen. So hello everyone, again, I'm Megan Lucey, just so you know my voice. And this is a presentation about providing compassionate care for persons with HIV and AIDS at the end of their life.
And I'm Kiernan Riley, so we'll start with some objectives of the presentation. So we hope throughout this presentation that you're able to understand the historical significance of HIV and AIDS, particularly in the LGBTQ+ population. We hope that you're able to recognize barriers commonly experienced by persons with HIV and AIDS when receiving end-of-life care, and also explore best practices for providing compassionate care for persons with HIV and AIDS at the end of life. So we are about to pull a case study up on the screen that we're going to give everybody a minute or two to review and start to think about. We do want to note that while the case study is specific to somebody within the LGBTQ population, not all HIV and AIDS cases are within this population. However, we are going to be looking at the effects of discrimination and stigmatization in this population specifically. So I'm going to give everybody about a minute and a half to 2 minutes to kind of read through this case study and start to think about some of the factors that may be impacting Mr. L's care. So we'll give everybody about 10 to 15 more seconds to finish up. Okay, and next we just have some case study reflection questions to think about as we talked through our presentation. So how might the history of Mr. L's HIV diagnosis impact his perception of care today, particularly during his end-of-life period? What are lasting effects of healthcare discrimination that this patient might be experiencing? And then how can nursing interactions of the end of life and hospice nurse be inclusive and affirming of these experiences?
So to give some background on HIV, some of the statistics and a little bit of a review of the pathophysiology. So HIV spelled out is human immunodeficiency virus. Over 1 million people were estimated to have HIV in 2019. And the HIV virus targets the immune system cells, specifically the CD4 cells. And this increases the person's susceptibility to infections. So with HIV, the individual is very vulnerable to infections from this immunodeficiency. Then the advanced stage of HIV is known as acquired immunodeficiency syndrome, also known as AIDS. And in AIDS, this individual is severely immunocompromised. And if this HIV is untreated, it can progress to AIDS in about 8 to 10 years. It's transmitted through the blood, breast milk, and unprotected intercourse. There's no cure for HIV, but the progression can be slowed with antiviral therapy. And through this therapy, people can become undetectable, meaning that their viral load of HIV virus is undetectable. There's the message of U equals U, shown at the bottom. And this means that people with HIV who are virally suppressed cannot transmit HIV sexually, although they should still practice safe sex. Next, we're going to go over a little history about HIV. So it was first discovered in the United States in the 1970s, and it originated from people hunting chimpanzees for meat. Since its initial spread, it has been wrongfully associated with gay men. There was an initial incorrect belief that it spread solely through male-to-male sexual contact, but as we showed on the previous slide, it can be spread in more ways than that. There was significant discrimination as a result of widespread homophobia. And this discrimination and stigmatization led to the death of approximately 10% of the gay male population by 1995. With the stigma, there was also negative judgments towards those with HIV, which caused avoidance and isolation, which is not needed as HIV is not spread through casual contact. Some examples of the discrimination against people with HIV. There was a travel ban on HIV positive individuals entering the United States up until 2010, and gay men were banned from donating blood up until 2020. There's also internalized stigma, which means that people with HIV can have feelings of shame and despair, and this can have a lasting impact on those diagnosed with HIV. As shown in the case study, Mr. L was uncomfortable discussing his diagnosis. And some people might ask, why should we learn the history? Because the stigma has improved, but it still does exist across many communities. It's very important to consider the unique nature of HIV and the history of this diagnosis, and the impact of perception on healthcare professionals due to this history of discrimination. There's some older adults, such as in our case study, who may have struggled with this diagnosis for a long time. As we saw, Mr. L had HIV for 35 years, and some of these people have lived through the initial epidemic of HIV.
So we're now going to show a video. This is a trailer for a movie called 5B. This is a documentary that is available for free online, and Penn State also has access to this documentary. It's a documentary that focuses on the initial spread of HIV and AIDS in the 70s and early 80s, and focuses on the nurse-led interventions that really did change the face of the world and how HIV and AIDS was cared for. So while it is a movie documentary trailer, it also does have some historical significance and background. So we kind of have two objectives in showing this: to show some of what was going on in that time period, and also to encourage all the attendees to watch the documentary. It's a really, really fascinating look at a nurse-led initiative.
The 70s were about that attempt that we made to carve out a place for ourselves in society that had never been done before. It is a big deal.
1981 was when things really began to change.
We had patients that came through with this illness. Within a month or two, boom, he was gone.
Nearly 3,000 cases of AIDS have already hit this city.
Nobody even knew how it was spread.
They wanted to quarantine us on an island.
I had seen patients being marginalized, and I just found it infuriating.
We were expected to wear what we called spacesuits, and some would refuse to give care.
We have to do something.
At San Francisco General Hospital, the staff is gearing up for the opening of a special wing to treat AIDS victims.
The nurses there physically built that ward. They made the rules as they went along.
I don't want nobody here to give up. And I don't think that they will.
I saw what a toll it was taking on us.
I was drinking more every night.
I remember having recurrent nightmares.
We were being attacked on all fronts, politically, medically.
There was a guy who had applied for insurance, and they couldn't ask him if he was gay. So they said, have you ever worked as a florist, a hairdresser, or a decorator?
There were still nurses operating from fear.
They went to the union. We don't want to take care of these people.
I might have some anxiety about this, but I'm more pissed off and angry than I am scared.
Why not bring life and laughter and joy?
This was a tangible thing you could do. It's just part of nursing.
They stood up when nobody else would, and they were willing to take those risks.
And they're all kind of kick-ass, even the straight ones.
So we hope everyone takes some time to watch that documentary because it is available through Penn State and for free online. And it is a really informative documentary about some of the culture that was happening at that time. So next, we want to discuss barriers to effective care for persons with HIV at the end of life. So something that we've touched on already in this presentation is the presence of discrimination. So historically, there has been a history of discrimination against people with HIV and AIDS through specific policies and laws, as Megan discussed. But even on a much smaller, more person-to-person level, there is a lot of judgment and stigmatization that goes on. And this could prevent somebody from pursuing care for their HIV or AIDS. There could also be a lot of fear around the diagnosis. So there's stories of people who have been diagnosed with HIV, but are so afraid of the illness, it paralyzes them from receiving more care and pursuing more care. So really trying to work with patients to overcome those fears. We know today that it's U equals U, which was earlier in the presentation. So undetectable equals untransmittable, which means a long lifespan as well. There's also a lack of access to care for those with HIV and AIDS. We know that there's higher rates of HIV and AIDS. They're the highest in our homeless and uninsured population. Antiretroviral medications, which are able to help somebody have an undetectable viral load, are daily medications. It's usually a course of multiple medications, and they're very expensive. So it's necessary for somebody to be insured to receive quality HIV care, which we know is not the case for everybody. Specific to the LGBTQ population, there may be more nuanced barriers. Legal marriage only started for persons in the LGBTQ plus population in the last decade. So it's really important to identify who their long-term partners are, who they may identify as their husband or wife, depending on whether or not that there's legal background for that. There may also be a lack of support specific to their LGBTQ needs or experiences. This would be coming from the healthcare standpoint. So it's important for providers to understand this. And then there may also be cultural differences within the LGBTQ population that we should be aware of and incorporating into care. For example, definition of family changes very frequently within the LGBTQ population, and something such as chosen family becomes much more important, and equally, we as nurses should be equally valuing this as their family members, as if they were related by blood. And finally, there's provider barriers that may be occurring. So this can be a lack of education for providers, a lack of knowledge, or a lack of understanding. There is still today stigmatization against persons with HIV and AIDS on the healthcare and provider side. And this also occurs for people in the LGBTQ plus community. Therefore, it's really important to understand personal biases and biases that may be coming from coworkers or other providers in order to address them.
So a review of some of the methods that were used in this study. We used a literature review of scholarly databases, including CGNE and PubMed, and some of the keywords were HIV, AIDS, hospice, end-of-life care, stigma, LGBTQ, and a combination of these words. So some of the best practices we found, I'm going to cover some ones related to physical symptoms. People at the end of life with HIV may experience a lot of different physical signs and symptoms that hospice can help relieve. The 3 that we have here are specific to HIV, but they could also have more general symptoms such as dyspnea. So starting off with diarrhea. This could be a side effect of the antiviral therapy that they take. It could also be a result of opportunistic infections. Opportunistic infections are a significant part of the AIDS diagnosis. As the immune system declines, they get more infections. The treatment for this would be antibiotics if the underlying cause is an infection, adequate fluid and nutrition intake, and skin barrier ointments to prevent breakdown. Also loperamide, which is also known as Imodium. The next symptom is fever, which can also relate to the opportunistic infections. Some treatment for this would include adequate fluid intake, cool sponges and fans, acetaminophen or NSAIDs. And last is neurological changes. There's such a thing as HIV encephalopathy, which causes slow motor function, abnormal movements, progressive cognitive decline. Something that can help is physical and mental exercise and cognitive rehab, but as the HIV encephalopathy worsens, it can cause delirium, agitation, and changes in mood. And some medications that can be used to help with this are haloperidol and quetiapine, which is also known as Seroquel. And there's also cannabinol-based products.
So just like with physical symptoms, there are many psychosocial experiences that somebody may be going through at the end of life. We're going to focus specifically on depression and anxiety, as those are the most common. In persons with HIV prior to their end of life period, they're about 61% of those with the diagnosis will experience depression. In the end of life period, depression is also very common. However, at the end of life, depression is often missed or misinterpreted as part of the normal dying process, because a lot of parts of the normal dying process look very similar to depression. For example, they both can look like changes in behavior, mood, appetite, or cognition. So eating less, being more withdrawn, having less energy. So it's really important for nurses to assess for depression specifically to help differentiate that using items such as the PHQ-2, which we're going to take a look at in a second. If the patient is found to be experiencing signs and symptoms of depression, as opposed to just that normal sort of end of life decline that they may be experiencing, it's important for nurses to address this with both pharmacological and non-pharmacological measures. So pharmacological measures for depression, it's recommended that SSRIs are used in the end of life period. We know that they take a few weeks to work, so it's important to be assessing early as soon as we're interacting with these patients and starting treatments early to help alleviate some of those depressive symptoms, particularly in the end of life period. So this can be medications such as sertraline or escitalopram that can be utilized in the patient. When using pharmacological measures and around them, it's important to also be utilizing non-pharmacological measures. So a lot of these that I'm going to talk about are going to overlap with what we can use for anxiety, but many of these are also covered by hospice insurance benefits. So they can include things such as Reiki therapy, aromatherapy, pet therapy, or music therapy. A lot of times, most hospices may already offer these. You just have to ask for them, and they can be really effective in reducing depression or anxiety, which we're going to talk about in a second. So, but first I wanted to show the PHQ-2. So it's the Patient Health Questionnaire -2, because we're only asking 2 of the questions specific to depression. There is a longer version, I believe it's the PHQ-9. However, the PHQ-2 is very easy to fit in an initial or ongoing assessment because it's only 2 questions. So the questions are based over the last 2 weeks. The nurse can ask the patient, how often have you been bothered by the following symptoms? So number one is little interest in pleasure or doing things, or number two, feeling down, depressed, or hopeless. If the patient responds with several days, more than half the days, or nearly every day, they get positive points for that. If a patient has any positive score over 0, it's important to do a more in-depth depression screening. So this is a way to help differentiate if your patient is just experiencing end-of-life symptoms or depressive symptoms. And then also looking at anxiety, this can be very common at the end of life and can be heightened in those who might be also experiencing an HIV or AIDS diagnosis. So the presence of anxiety at the end of life can impede comfort and communication and can look like changes in comfort and rest. So sometimes patients just can't calm down. They might be in the bed, but are agitated, shuffling, wrestling with their blankets and things like that. And it could also look like a change in thoughts. So racing thoughts, repetitive thoughts, kind of thinking about the same little problems over and over are symptoms of anxiety in patients at the end of life. And again, we want to look at pharmacological and non-pharmacological management. So those non-pharmacological strategies, such as aromatherapy and pet therapy with depression, would also be very helpful with anxiety. And then pharmacologically, we can use low doses of lorazepam or alprazolam to help reduce anxiety immediately for the patient. And it's also important to involve family in this. So a lot of end-of-life support comes from family members. So including family members in education, anxiety reduction tactics, some of those non-pharmacological management measures. And just a reminder, if we are talking about the LGBTQ+ community, going with their definition of family and understanding that families might look different.
And so the last best practice is inclusive and affirming patient-provider communication. So it's very important to deliver culturally competent care and develop knowledge, sensitivity, and communication skills. It's very important to have an understanding of some of the unique struggles that an individual with HIV may face. Research has shown that providers need more education on sexual and gender minority communication, history, and culture. So this could be done through staff training, but it's also important to integrate this at the educational level, such as nursing or medical school, before these healthcare workers even reach the bedside. The next one is a safe and inclusive environment. So this can be achieved through using diverse individuals in recruitment and using gender-affirming language in materials. Gender-affirming language is also important to use during communication with the client. This will help create a safe and inclusive environment. The next one is to establish a rapport with the patient and the family, which is always helpful. And then last, it's important to regularly reflect on any implicit bias that may negatively impact care. An example of what this may look like is taking some time to self-reflect before you interact with this client about any implicit biases that may negatively affect the care. And all of what's on this slide is very crucial because the goal of care, especially at the end of life, is to provide compassionate care to this individual.
So this is the resolution of the case study following the implementation of some of the practices that we talked about throughout this presentation. So I'm going to give everybody about 2 minutes to read through this and kind of think back to those reflection questions. How was he impacted by a history of HIV? What were some things that the nurse can do to provide more affirming care? And we invite you to think about that throughout this case study wrap up. So I'll give everybody a few minutes. So I'll just give everybody about 10 more seconds. Okay, and now we will just move on to our conclusions and takeaways. So some things that we hope that you were able to take away from this presentation is that HIV and AIDS is common today. So we're still caring for patients all the time who have a HIV or AIDS diagnosis, with approximately 30,000 new infections per year in the United States. The diagnosis of HIV and AIDS is historically associated with significant stigma. So it's important that when we are caring for persons today with HIV or AIDS, that we are recognizing the impact of the stigmatization and taking that into context when we are providing care for them. And it's important to note that the LGBTQ+ population has unfairly received the most stigma and discrimination since the discovery of HIV in the 1970s. And as Megan pointed out, many of the older gay adults who lived through that initial epidemic, we're still caring for them today, and they have lived through the history of this, and that may impact how they perceive care now. So the nurse should recognize the history and impact of this disease when caring for persons with HIV and AIDS, particularly at the end of life, when a lot of that life review starts to come back. And it's really important for nurses to address at all times in the end of life period any physical or psychosocial symptoms that the patient might be experiencing that would be taking away from their comfort and rest. We do have references available, and we're happy to take any questions about the presentation. Thank you.
Well, thank you so much, Kiernan and Megan, for an outstanding presentation. It was just so interesting. I really appreciate you sharing that historical perspective. I graduated in 1981, so you certainly reminded me of some of the experiences I had as a nurse in acute care at that time. Remembering, a nurse, for example, that refused to take care of someone with HIV/AIDS at that time, or remembering a friend of the family who, when he was starting to decline, the ambulance came to the house and refused to pick him up and take him to the hospital. So some pretty profound experiences, and I do believe and agree that that stigma and that discrimination is still present to an extent, and that it's so important. And thank you so much for the reminders of, it's so important for us to have knowledge and awareness and to be aware of those things as we try to provide compassionate care. So thank you for this outstanding presentation. We are going to pause for just 2 or 3 minutes to allow participants to complete the evaluation tool. Jenny has put the link in the chat. Thank you, Jenny. So if people can take a few moments to complete that evaluation. If you're an RN and you want contact hours, you do need to complete that, but we encourage all participants to give us feedback on the presentation and the seminar. While people are completing that, if you have, I see some comments and questions coming into the chat already, please take the time to continue doing that as well. So again, we're going to pause for just a couple moments, and we'll be back for some discussion and Q&A.
We do have a hand raise from Mike Evans. So in the meantime, I'm going to unmute him. And Mike, whenever you are ready, you can ask your question.
Thanks, Jenny. I was in the middle of my survey. I'm back. So first I want to say great job to Megan and Kiernan. I'm like a proud old dad here watching the two of them and watching Kiernan now mentor students herself. So I think, I don't have evidence to support this, but students that are Megan's age I hope, will have less stigma as nurses than nurses, say, my age in their mid-40s, due to the way culture is today and society is today, which I'm praying and hoping is better. So Kiernan, the question is actually to you, though, of course, because you're out of state now. I don't get to bother you as much. So you are a new professor, my friend. How are you going to prepare your students for difficult conversations surrounding topics like this that are crucial? It doesn't have to be HIV/AIDS, it doesn't have to be LGBTQ, just difficult conversations that put them out of their comfort zone and be ready to roll, because we know new graduates today need to be ready to engage.
Yeah, I think that kind of a philosophy that our school has taken is that practice is what sort of helps with that and gets you more comfortable with that. So something that we do, we were actually just talking about this in simulations, is we make sure that we ask or start those very difficult conversations as part of our simulations as kind of another objective. So for example, this semester we had an end of life simulation where the main focus was them being able to go into a home setting and give the medications in a home setting in a safe and effective manner, so that we know that they're able to give medications. But we had the patient ask questions such as, am I going to die? Is it going to hurt? Things like that, that did catch them off guard, but kind of gave them more of the chance to practice that. I don't have data on this, but a lot of students said that they felt that they learned from that situation and they might not be as scared the next time. But they all agreed that they needed more practice. So I think that the best thing with that is to get people more comfortable with those conversations is to have them more often. So
I couldn't agree more. I think experiential learning is the way to go with that. And students need to be told up front, this may be uncomfortable for you, and that's okay. And if they do have biases, we've all grown up in different environments, that they need to recognize that and work towards bettering themselves, I guess would be a way to put it. So nice job, guys.
Thanks, Mike.
Just to kind of take off on that topic, Mike, thank you for exploring that with Kiernan. I'd like to ask Megan, as a fourth year undergraduate student here at Penn State, I guess I would love to hear you share some of your experiences with in education that has helped to improve your knowledge, your awareness, and your sensitivity around these areas, and maybe even some ideas about things that we could improve.
I think something that's helped is the diversity of the classes that I've taken, because I've taken so many different classes as an undergraduate, and especially now in my last year. And I think it helps to get different perspectives on these issues. So for example, taking psychology, taking sociology, so many different angles of looking at these topics and how it's approached differently. And I think something that could help, trying to remember the word for it, we had a simulation in one of my classes where it was supposed to be interdisciplinary. So learning more about how different people from different disciplines could work together on an issue. And I think that's a very good idea of how to handle something while collaborating with other people and how they might have different perspectives that can really help.
Yeah, I love that. Just having that awareness that people are coming to their profession, coming to their work, coming to their life experience from different experiences, and that they may have different knowledge, different skill set or perceptions, and the ability to kind of recognize differences, but also to work with those and then help to raise awareness as you are working with them as an interdisciplinary professional. That's a great thought. Amanda, lots of positive feedback in the chat about the presentation, about some of the content and the video that you shared. One interesting comment, or many interesting comments, but Amanda writes, I feel like this could be similar to how scary and unknown COVID was at first. So I'd like both of you to comment a little bit about, any similarities that you see between, the COVID pandemic and how people responded to that, and, perhaps the history of HIV/AIDS.
Yeah, Janice, even when you were talking about your experience as a new grad in 1981, I've talked to a few other nurses who graduated in that 79, 80, 81, 82 timeframe. And it's very similar to nurses who, especially at the very beginning of COVID, when it was very unknown, there was a lot of unknown, a lot of nurses, as you said, Janice, just refusing to care for certain patients. I think that the difference, one of the major differences is that at the time, many were under the impression that HIV can only affect gay persons or people in the LGBTQ community. So they were there was a kind of an attitude of, well, it's their fault, it's their problem, and I'm not going to get involved in that. Where as COVID from the beginning could affect anybody, we understood that it could affect anybody. But I think that might have been a cultural difference piece, but there are a lot of similarities in especially the nursing perception of care. So
yeah, those are the important context. Yeah, absolutely. And certainly with older adults during COVID, you could see ageism more prevalent. Well, it's older adults that are getting this, is it that important, because they're older anyways, or they're in the nursing home, so they're there to die anyways, that kind of stigma and discrimination. So yeah. Megan, did you want to comment at all about that as well?
I would just add that I do think there's a similarity in that with HIV, there were so many unknowns when it first happened, and no one knew like how is it spreading or things like that. And I can kind of connect that to COVID and how when it first came out, people didn't know how it was spreading. Everyone was scared. So I think that's a similarity.
Yeah. Yeah. Thank you for sharing that. So lots of, again, positive comments in the chat about how thought-provoking this presentation is, and a level of appreciation for the ideas and the strategies you suggested, especially around the importance of effective communication and that compassion that we need to share as nurses and other healthcare providers. There is an undergraduate nursing student that mentions that she needs documentation of her attendance for class. If you are an undergrad, if you can just put your name in the chat, we'll make sure we relay that information to your instructor. Thank you for doing that.
We do have a hand raised from Sarah Songer.
Okay.
I just wanted to make a comment. It's going to be because of what you were talking about the changes with the COVID and what you've seen. Being a nurse of a certain age who was there when HIV started and had to deal with a lot of the things that you were talking about. What was so interesting was before then, when I was a nursing student, you washed your hands between patients. You couldn't afford gloves. You didn't have gloves. And now you look at it and you say the whole world's changed because you don't go anywhere without gloves. And people forgot to wash their hands now. You think they take the gloves off. With the COVID, the change with the vaccinations and the expectation that we're going to have vaccines or we're going to have treatment in weeks or just such a short period of time. I look at that and I go, that again changed the whole, what do I want to say, perception and what people are going to expect out of healthcare.
Yeah, thank you for those comments. Kiernan?
Yeah, it's true, Sarah. And I think the 5B documentary covers a lot of this. But HIV and the spread of HIV in the 80s was when people started to wear gloves to draw blood, for example. So they were saying that was a major change when this started to spread, was that now we have to wear gloves when obtaining blood specimens, which to us would seem so obvious. It would be probably a clinical failure if students were drawing blood without gloves. But back then, that was the standard of practice.
Yeah, I remember having to, palpate for a vein, when starting an IV and thinking, how am I going to do this with gloves on? So, some of the things I was thinking about from a geriatric perspective is, you acknowledge that when we're taking care of older adults, they might not disclose their sexual identity. They might not feel comfortable because of the different life experiences they've had, or maybe they haven't even fully shared it with all of their family members, or their HIV/AIDS status. Can you comment a little bit about that? If you were caring for an older adult, how you might approach that communication and that sensitivity, and you talked about the importance of building rapport, but some of that information is so important, like right up front, as maybe you're admitting a patient to the hospital or something. Can you speak to that?
Megan, and I don't know if you have anything to add, but I think that particularly in cases like that, where somebody may not want to disclose their sexual orientation or their HIV status, which it's not required by law to disclose your HIV status. Oftentimes it's not disclosed even upon hospital admissions, because if we're using our standard universal precautions, there should be no possibility of transmission. So you're not required to disclose that. And I'm actually going to pull from the comment section to answer this. Megan McGraw mentioned ways of being versus ways of doing. So I think that there is a huge difference between showing up and going through our skills and our checklist and getting what we need to get done to fulfill our job description versus, which would be a way of doing, versus showing up and kind of maybe even opening that conversation up early. And if they're not comfortable with it, they don't have to respond or engage in the conversation. But if we're showing up, kind of keeping that context and awareness in our mind and keeping the context of human beings and their lifelong experiences in our mind, I think that we're able to kind of show up in a way that can build rapport with those types of patients to make us be somebody that they would feel comfortable sharing that with and would like to share that with. So I think that we can just show up just to do, or we can show up kind of with that way of being to bringing all that knowledge and theory kind of behind us to our patient interactions.
Yeah. Well, and I really appreciated your sharing of the trailer, and it certainly sparked my interest in watching the full documentary, and I hope other participants will be doing the same. One quote that really popped out for me, and I wondered if, Megan and Kiernan, you can comment on this. One of the nurses said, "Why not bring life, laughter, and joy to their situation?" So can you share a little bit about how the nurses did that in that very difficult situation?
Yeah, so they showed a little bit in the video, and I know it was a little jumpy, but the nurses used to come dressed in costumes, and there was a lot of music brought to the unit, a lot of parties brought to the unit, brought into people's rooms. They did not have visitor restrictions. They did not have familial proof requirements for visitor restrictions. So there was a lot of sense of community on the ward. And one of the things that they really did that I thought was really impressive, that they talk throughout the documentary to kind of bring more love to the unit, was it's really impressive in the documentary. They touched the patients, and not only did they touch them without gloves, but they would get in bed with them and just hold them. The nurses would just get in bed and hold the patients. I get emotional every time I even think about that documentary, but it's an amazing, this documentary really shows kind of the length to what being a nurse means and how far we can go. And that unit itself, that 5B, really did change the way that the world cared for people with HIV. They really changed kind of the face of it. So can't recommend it enough.
Yeah. Did you want to comment on that as well, Megan? Was there anything that popped out for you that the nurses did that you found especially impactful?
I definitely think, like what Kiernan said, just making it a more positive experience, because I know sometimes you walk into a hospital room and it's sad, it's dark, but there in the documentary, they're making it a bit more happy and dressing up and laughter. And that's important to make it positive, not just negative.
Yeah, and I'm gonna let the cat out of the bag here a little bit, Megan, but Megan shared with us before the presentation that she's accepted a position in an intensive care unit after graduation, which is going to be coming up quite soon. How do you think you'll bring some of those concepts into the work that you're going to be doing? You may have some patients with HIV/AIDS, but you'll have many others that need compassionate care as well. So what are some of the strategies you've learned through this work, through this study, that you can bring to your future life as a nurse?
I think it's very important to focus on their family and like having them in there, involving them. And especially something we mentioned in this presentation is who they define as their family. So it could be friends or neighbors or the people that are important to them. It's very important for their family to be involved and to be there.
Yeah, thank you for reminding that is a key concept, helping we make assumptions sometimes about who is important to the patient, and really asking those questions about, who are your supports? Who are the people that help you make decisions? Who are the people that you want to have information communicated to? Those pieces, really making sure we're clear on that. Kieran, you look like you wanted to comment on that. Oh, no, okay. Okay.
We do have another raised hand by Eileen.
Okay.
Hi, everybody. I just want to congratulate Megan and Kieran, both who've worked for me as tutors. But I also want to just make a couple of comments. And one is that it is very important to continue to raise awareness. I think a lot of the public thinks that HIV and AIDS is a non-issue anymore. And Megan, I'm glad you brought up the piece about family, because that was one of the things I wanted to comment about. I lost my brother to AIDS 20 years ago. And I think that it was wonderful how your research, in the case study, you included the partner, and not only during the experience, but also it looked like to me you provided support after his partner had passed away. So I think that that's important to highlight, is the impact on the family, and that there are resources that can be provided to support the family as well. So I thank you for doing this work and sharing this information. So
Eileen, that's such a great point. So Mr. L's partner in our case study, fictional case study, by the way, was able to receive bereavement services for 11 months following the passing of his partner. This is not the case in all hospice facilities. The one I work at, for example, provides bereavement services for life following a passing. Some provide it only to legal family members, such as a spouse or a child. Some provide it to any who feel like they're suffering with the bereavement following a death. So this is a really actionable point, that end-of-life facilities can change their policies to provide these end-of-life services to anybody who may be experiencing bereavement or difficult bereavement following the death of somebody. So I think that that's a really important point.
Yeah, thank you. And thank you for your comments, Eileen, and I'm sorry for your loss. Diane Barish is asking, did you find any strategies to help nurses be advocates for their patients who may not have the same strength of voice within the healthcare system? And did you see any approach as being particularly effective? So strategies related to nursing being advocates for their patients. Anything in particular, whether it was in the documentary or any of the literature that you reviewed?
So I think first and foremost, it's important to recognize what they need to be advocated for. So For example, if we aren't thinking about this historical context and impact that the history of HIV might be having on them, we can't really advocate for them beyond that. So kind of coming to them with the whole human picture, leaving open room for communication to figure out what it is exactly that they need. And then depending on where you're working, following that ladder, using your nurse supervisors, your nursing resources to start to draw in things that can help them, or if it's something that needs to be a systemic change. We all are trained in advocacy techniques and how to communicate with leadership and things like that. And I think maybe drawing on those tenets can be really useful. But I think first and foremost is kind of showing up to patients ready to figure out exactly what their needs are.
Excellent points. Thank you, Kiernan. Annette is mentioning that she thinks it's a great point that not all HIV cases are in the LGBTQ community, that her first HIV patient that she cared for was infected by a tainted blood product. He had hemophilia. One thing I was curious about, and I know we're, starting to get towards the end of our time, is are you aware of any particular data related to how many older adults have HIV/AIDS? Because I think that sometimes the perception is that it's not in that population. But what are your thoughts on that, or what were some of the information you came across related to that?
So I'm not sure about older adults specifically, but I know globally, getting to Annette's point, right now, over 60% of cases of HIV are in women who do not identify as part of the LGBTQ community. So that it is really just not associated with it. That just happened to be where it started to be discovered.
So over 60%, you said?
Over 60%, yeah, in today. But I'm not sure about the breakdown between ages, but I know that it's really important to start to come away from that association of HIV and LGBTQ. We did want to include it in the case study due to the way it may impact their care and perception of care, but yes, it's really not as associated.
Yeah, there's certain, several layers of stigma or potential discrimination if you're, so I think that was important. I really appreciated the fact that you emphasized the need to differentiate between depression and end-of-life decline because of the similarities in some of the symptoms that you may observe, and the importance of assessing, for anxiety or depression at that point. I also really valued the non-pharm approaches and didn't know that hospice services would pay for some of these specialized things like Reiki. Do you want to comment a little further on that at all?
I think that does come down to a hospice by hospice. But I've worked, and the one I currently work for, we offer Reiki services just as part of what we offer at some of our non-pharmacological approaches. I think it's really important to assess sort of what's available in your area. And this could also be another great advocacy point for nurses. If your hospice does not offer these services, maybe this is something that you could advocate for your patients, because these are things that are shown to be effective in reducing depression and anxiety throughout the course of a lifetime and also at end of life.
Yeah. All right, well, we are at the end of our time. So I want to thank you, Dr. Riley, as well as Megan again, for an outstanding presentation and a great discussion. We really value the work that you've done and continue to do. And thank you so much for sharing it with us today.